Hello, everyone. Good afternoon or good morning, depending on where you are. We will give a couple minutes for everyone to join the webinar and get themselves situated, and then we will begin. I will direct your attention to the slide on the screen. So this webinar will be recorded, and the recording will be available after today's session. Just to note that everyone's microphone and camera will be turned off for the duration of the webinar. And if you desire, you can turn on the live transcriptions for this webinar, and that can be enabled from the Zoom control panel at the bottom of your screen. So again, we'll just give a couple minutes for everyone to join and get situated, and then we will jump right in. Okay, so as everyone is still joining here, just a couple reminders, this webinar will be recorded. For the duration of the session, everyone's microphone and camera will be turned off. And if you wish to, you can enable live transcriptions from the Zoom control panel at the bottom of your screen. So welcome everyone to today's session on using AI in rapid reviews, applications, and screening. My name is Alana Miller. I am a research coordinator here at the National Collaborating Center for Methods and Tools. And we're happy to have everyone joining today to learn a bit about how you can use AI in the knowledge synthesis process. Just a couple housekeeping items before we jump into webinar content. We have disabled the Zoom chat function here for today's webinar, but if you are experiencing any technical issues or if you have any questions, please indicate in the Q&A. You can leave any notes there, and Krishan Camargo, who is joining from the NCCMT, will help address any of those technical issues. We will also be using the Q&A for our question and answer session throughout the webinar and at the end of the webinar session. So please post any questions that you have there, and we will happily address those at the end. And then lastly, we will be doing a little bit of polling throughout the webinar session. So when a poll is running, you'll see it pop up on your screen. You can simply just answer the poll and the pop-up box should go away. So as I already mentioned, today's webinar will be recorded, and after the session, you will be able to access both the webinar recording and a PDF version of the slides from your NCCMT dashboard. You can also access the recording available in English from our YouTube channel. And if you would like a PDF copy of the slides, you can also email us at nccmt@mcmaster.ca. We will post on our LinkedIn when these are available, but it's usually about a week or so after this webinar session. So here at the National Collaborating Center for Methods and Tools, we are funded by the Public Health Agency of Canada, and we are affiliated with McMaster University. Production of this webinar has been made possible through a financial contribution from the Public Health Agency of Canada, and the views expressed here do not necessarily reflect the views of the Public Health Agency of Canada. The study that Sarah is going to be speaking about today was supported by the Health Research Board in Ireland and the HSE Public Health Agency grant through Evidence Synthesis Ireland and Cochrane Ireland. I would like to acknowledge that McMaster University, located here in Hamilton, Ontario, is located on Treaty 3 territories, and that is under the traditional territories of the Mississauga and Haudenosaunee Nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. So at this point in time, I'm going to ask Krishan to launch our first polling question for today's session. Here we just want to know if you have heard of the NCCMT before. Have you visited our website or used any of our resources before? And if that answer is yes, how many times have you used the NCCMT's resources? This just kind of helps gauge who our audience is. And it's just kind of interesting for us to see how many people have heard of us or have used our stuff before. So I'll give a couple seconds here for people. Looks like lots of responses are coming in, so that's great. And as you continue to answer those polling questions, I will continue. So, the National Collaborating Center for Methods and Tools is one of six collaborating centers, part of the National Collaborating Centers for Public Health. There are six different centers across Canada, and we each focus on um, different aspects of public health, and we work to strengthen and support public health to use evidence. There is the Center for Indigenous Health located in British Columbia, as well as the Center for Environmental Health. We have the NCC for Infectious Diseases located in Winnipeg. We have our center, which focuses on methods and tools for evidence-informed decision making, located here in Hamilton, Ontario. There is the Center for Healthy Public Policy in Montreal, Quebec. And then out in Nova Scotia, there is the Center for the Social Determinants of Health. As I mentioned, the National Collaborating Center for Methods and Tools focuses on facilitating and scaling evidence-informed decision-making in public health, and we do so by providing a variety of different resources and training opportunities to those working in public health. And similar to the other NCCs, our goal is to improve the health and well-being of all people living in Canada. Okay, so I am happy to introduce today's speaker. We are joined by Dr. Sarah Neal Stramko, who is the co-scientific director of the National Collaborating Center for Methods and Tools. And without further ado, Sarah, I will pass it over to you to take us through today's content.
Great. Thank you, Alana. And thank you, everyone, for joining us today. We're really excited to share some of the ongoing work that we've been doing at the NCCMT related to use of AI and screening in our rapid reviews. Next slide, please. So just to give a little bit of an overview and background of where this project originated from. So early in the during the COVID-19 pandemic, the NCCMT launched a rapid evidence service. So some of you may have been familiar with our work prior to the pandemic in supporting public health units to conduct their own rapid reviews as part of their evidence-informed decision-making process. But when the pandemic struck, we know that people were being reallocated and redeployed to other areas of pandemic response. And we also knew that there were a lot of the same questions that public health decision makers had across the country related to the pandemic. So we launched our rapid evidence service to answer some of these priority public health topics. And we've continued on since the pandemic to continue to answer questions from public health decision makers at a local, provincial, national, and international level. We apply internationally accepted methodology for conducting rapid reviews and try wherever possible to engage with public partners to bring that lived experience perspective to the reviews that we conduct. So to date, since our first review was completed in May of 2020, we've completed over 100 rapid reviews or updates to rapid reviews on a number of public health related topics. And Christiane, I've noticed, has just put into the chat a link to our finished and published rapid reviews, as well as a methods paper that we published in 2021 that describes a little bit more of our rapid review process in depth for those who are interested. Okay, next slide, please. So just to give a little bit of an overview, we follow a bit of a pass the baton method within our rapid evidence service so that we can complete our reviews in a timely manner. So we start with defining the question, searching, appraising, and synthesizing the evidence. If you could just click to the next piece of the slide. So here's starting with defining the question. So we work with our requester or public health decision maker who's looking for this evidence to really understand what it is that they're looking for and define our inclusion and exclusion criteria for our rapid review. Then we conduct a comprehensive search of the literature using a combination of academic publications as well as gray literature sources, depending on the question. We do a rapid screen for relevance, so title and abstract screening, and then looking through to the full text for those abstracts that seem relevant. Then we critically appraise the available evidence using validated tools. Most often we use the Joanna Briggs Institute or JBI suite of tools, using the appropriate one for the appropriate study design. Then we extract some data, summarize our key findings, apply the grade process to rate the certainty of the evidence, and synthesize those findings into an executive summary. Next slide, please. So, really, what we find takes us quite a bit of time in this process is screening for relevance. So, we search the literature, we have hundreds or thousands of results, and we know that only a handful of those may be actually relevant to our question. And so, this is where we think that AI can have a really important impact and have potential to automate and expedite that screening process. At the same time, we want to be really cautious and making sure that AI is not introducing any unintended biases or errors into that screening process. And so that's where the question in this study came from, is really how can AI be used to expedite that process, but in a way that we feel is trustworthy and rigorous and not introducing additional biases. Next slide, please. So this led to an application that we put into the Evidence Synthesis Ireland study within a review competition around this time last year. And we had two main objectives. First, does the use of different AI screening features result in any missed studies compared to manual screening? And if so, does this change our overall findings in terms of how the certainty of the evidence using grade and the magnitude or the direction of the effect? So, given that these are rapid reviews and we're conducting them in really tight timelines to meet decision maker needs, it may be okay if we miss one study within 30 studies that might be included. But really, does this, what we want to know and what's kind of most important is, does this change our overall summary or confidence in the findings? And then secondly, how does AI compare to AI assisted screening compared to manual screening on the time to complete the review? So thinking about sort of the costs and benefits of using AI in screening in a rapid evidence synthesis, we want to look at both sides of the coin. So how much time are we actually saving? And does this balance out potential of a missed study or two in that review? Next slide, please. So an overview of our sort of data set that we used for this, we first used one update to a previously conducted systematic review that we had been doing on contract with colleagues at the University of British Columbia. So we used that for our proof of concept. And then we did seven reviews that were completed using our typical rapid evidence service that were sort of our data points for this project. So the first was on risk factors for invasive meningococcal disease. The second was on interventions that can enhance school engagement. A set of three reviews looking at the impact of wildfires. First, the effectiveness of air filtration during wildfires on health outcomes, using masks on health outcomes during wildfires, and the impact of different public health messaging strategies on behaviors, knowledge and behaviors during wildfire situations. The sixth one was looking at interventions to reduce sexual orientation and gender-based violence in school settings. And lastly, one that looked at the inclusion of pregnant and lactating people in clinical trials. So a really wide range of topics. And as is common in our rapid evidence service, a lot of what we call sort of messy questions. So these are not questions that are typically answered using really clean randomized controlled trials. These are sort of a good representation of the types of questions that we get related to public health, which are often utilizing a number of different study designs, have a lot of sort of inherent messiness in them. So a good snapshot of what we typically see in our rapid evidence service. Next slide, please. So we use Distiller as a software to conduct all of our rapid reviews, and you can kind of click, if you can click through to show everything that's on the slide, please. And Distiller has a built-in artificial intelligence features within the software that it provides to us. So just to sort of base our what we did in that, and that we didn't actually create any of our own artificial intelligence models as part of this. This was all using the pre-established features that are available to anyone who's using Distiller. So there's four kind of AI features that we utilize in our rapid evidence service. The first is the DAISY rank function. And so this is a function that reorders studies based on relevance. And it learns as you continue manual screening. So we conduct our search of the literature, upload all of those results into Distiller. And typically in a rapid review, when you're using any kind of software to track your screening, you sort of just go through and it's either in alphabetical order or it's in order of the reference ID, and you start to screen and you'll have some includes, some excludes, and it's just kind of in a random order throughout. But by using the Daisy re-rank function, oh, can you go back to the previous slide, please? Thank you. And just show that last bullet, please. Thank you. As you use the Daisy re-rank, it starts to learn from your screening as you conduct the first, usually about 100 studies, and it starts to bring studies that it determines are most likely to be included to the top of your list. So this doesn't actually use AI to screen any studies itself. It just brings the most relevant studies to the top of your list, which really helps from sort of a cognitive load perspective, in that you're seeing all of the relevant studies at once. And then as you get to the end of the list, you're seeing those studies that are really irrelevant that you can very, very quickly and easily say no to. So it sort of helps. We've noticed that it really helps to reduce our screening time that way. And it also helps in terms of us getting to that next stage a little bit faster. So as we're screening, we start to see that we don't have many relevant studies that are coming through now. We're starting to get to those really kind of irrelevant pieces. And so then the next members of our team can start on that full text screening or data extraction, while other members of our team are still finishing up that screening. And so we can sort of accelerate the process that way, and rather than getting through all of our screening before we're able to move on to data extraction. So that's one feature that Distiller uses. The second is what we call the re-rank report. So it predicts, based on the manual screening that you've done so far, the total number of included studies that you will ultimately have in your review, or at that level of screening. So it also uses the same information as your manual screening as the Daisy re-rank, and it lets you know how many of the relevant studies it predicts you found. So it takes a little bit of time to sort of calibrate, but then at some point you can run the report and it says, we predict that you found 60% of the 20 included studies we think you will find. That number is not always accurate, but it lets us know a little bit of where we are in that screening process and how many more included studies we're likely to find. And we used that re-rank number in our study, which we'll get to in the next slide. So again, the re-rank report is just a prediction, and it's not actually using the AI to make any screening decisions. The third bullet here, AI screening, is when we actually use the AI to automatically screen studies based on predictions from manual screening. So as you've screened a certain number, you get to that point where the AI feature can be used, and it based on a prediction score that it assigns to each reference that has yet to be screened, then it will either include or exclude based on that prediction value. And then lastly is there's a check screening errors function. So after you've finished your screening, you can run this model and it will let you know, it will provide you with a list of studies that the AI feature thinks you as a manual screener or as the AI screener has accidentally excluded or included based on the manual screening pattern. So it's a little bit of a double check function. Okay, next slide, please. So that's just a rundown of the different AI features that are in Distiller. So what we did within this study within a review is used that re-rank feature at different thresholds. So as I mentioned, as you're screening, it lets you know, we think you found 60% of included studies, 70%, etc. And you can see the screenshot here on the screen is an image of what you actually see as you're screening. So you can see within this review, the AI feature predicts that this person has screened, has found about 93% of the studies that will be included, and has already identified 14 of the 15 included studies in that first little box here. And then as you move over to the right, you can see in the review progress, you can see sort of as the manual screening has happened, we found very few includes as we reviewed the first roughly 50 studies. That's probably when the Daisy feature kicked in and brought the most relevant studies up to the top. And then you can see from about 75 to 200 manual references that were reviewed, we found a bulk of those includes. And then as we've moved on, we found very few includes there. So that just gives you a little bit of a snapshot of what it looks like as you're going through the screening. So what we did in this study is as we went through our manual screening, we what's called cloned the project when we reached each of these thresholds of 60%, 70, 80, 85, 90, and 95%. So essentially that means we've just taken a copy of the project, sort of frozen it in time with where we were at that point, and then continued screening. So we had copies of the same project or the same review that were where manual screening was paused when we reached 60%, another where manual screening was paused when we reached 70%, and so on. Then in each of these sort of cloned or mirror images of the same project, we used AI to screen those remaining studies. So we used AI to screen everything after 60%, everything after 70%, etc. And then in the original project, we did manual screening throughout. So we sort of had that control of what it would look like if we just used manual screeners throughout. And then we had sort of snapshots or examples of what the project would have looked like if we'd used AI at each of these different thresholds. Okay, next slide, please. And we will have lots of time for questions because I know this is a lot to wrap your head around, especially if you haven't used Distiller before. So then we compared the results of that AI-assisted screening at each threshold to the results of the manual screening in the original project. So we were able to identify and count the number of studies that were incorrectly excluded by AI, and then also look at the impact of those missed studies on the review key findings using our completed rapid review. We also were able to calculate the time, which we tried as best we can, and I'll talk a little bit more about some of our limitations at the end. But we captured the time spent screening, both overall and when we use manual screening at each threshold. And one thing I should mention now is that this was all screening at the title and abstract level. So just using that title and abstract, any of those studies were then screened in full using manual screening, so by a human, looked at all of the full text of those studies. So AI wasn't used entirely. This was just in that title and abstract screening level. Okay, next slide, please. Okay, now moving into our results. So as I mentioned in the methods, we had 7 completed projects that were analyzed for this study. The number of studies that were identified in our search that needed to be screened was highly variable, ranging from as little as 733 references to be screened to almost 12,000 references across each of those 7 projects. And when we look across the board, across all of the different thresholds that we tested, AI was able to exclude as little as 6% of the total number of studies to as much as 73% of the total number of studies. So huge variation in terms of how the impact that AI had on those total number of studies that could be screened and kind of removed from the manual screener's workload. Okay, next slide, please. And this is a graph that shows an average across the 7 projects of how AI was actually able to reduce our screening load. So after manual screening, the number of remaining studies that could have been screened by AI ranged from as little as 377 to up to over 8,000 across the different thresholds. So if we look in the graph here at 60%, when we used AI to screen at the 60%, when we reached the 60% threshold of manual screening, it was able to screen out about 34% of the total references and just under 50% of the remaining references that were at that threshold. So if we screened to 60% of included studies, it got rid of just under half of the remaining studies, which resulted in just over 30% of studies overall. And as you can see, as we move up at the 70% threshold, again, the number of remaining references that the AI was able to remove increases, which makes sense. As you've done more manual screening, there's more data that the AI has to work with, and it can more confidently exclude the remaining studies. Remember that we were using the DAISY function. So as we screened more of those studies, there were more of those really highly irrelevant studies that were left over. So it makes sense as you move more into those higher likelihood thresholds that more of those ineligible studies can be automatically removed by AI. But it looks like in terms of the total number of references that AI removes, around 85% seems to be that spot where we are able to remove the highest absolute number of studies from manual screening. So we're manually screening the least number of studies, around that 85%. But there was a high amount of variability across the 7 different projects that we looked at. And I think we can talk about some of the limitations, whether 7 studies is enough to really be confident in these numbers. But lots of variability. But right now it looks like 85% might be kind of that sweet spot. Okay, next slide, please. So this is just an example of one study on, this example is from our public health messaging during wildfires review. So here we can see when you can, again, similar to the image that we saw before, we started screening, manual screening. And as we got to probably about 300 studies, that's likely where the DAISY feature started to really work in our favor. So we found a few includes as we did those first kind of 300, 350 maybe references. And then when we got to that, we can really see we started to include quite a few studies as we moved. And you can see the graph moving upwards up till about 2,000 manual references. And then we really didn't see many more includes after that. And so when at this maroon line represents the cloning that was done at 85%. So the AI feature predicted we'd found 85% of studies, and we used AI to screen the remaining, and it screened out the remaining studies there. So just a little bit of a snapshot of kind of what that looks like as we were working through it. Okay, next slide, please. So most importantly, so we know that AI can reduce our screening load, but what does that mean in terms of accuracy? So in 6 out of the 7 reviews that we looked at, using AI screening at any threshold resulted in no missed studies. So there was nothing that we had manually screened using in our full original project where only manual screening was done. AI did not miss any of those studies in 6 out of the 7 projects, which was great news. However, in one of the projects, which was a review looking at interventions to enhance school engagement, use of AI screening did result in some missed studies. So when we used AI screening at the 80% threshold, we missed out on 2 different studies that were ultimately included in the review. And when we used 85, 90, 95% thresholds, we missed only 1 study. So this has potentially important implications for sort of our overall findings if using AI results in us missing studies that were ultimately included. And just to note that we calculated this based on, we looked at the number of missing studies based on those that were ultimately included at the full text level and made it into the final review. AI did exclude a number of studies that were at the title and abstract level that were manually included, but then excluded at full text, which we don't see as necessarily a bad thing, because if AI excludes something that we ultimately exclude at full text, then AI might have just been more accurate than the human screeners, because we know humans also make mistakes. But really what we want to know is at that final full text, what was ultimately included in the review. So not looking at sort of the accuracy of just title and abstract and moving into the full text level. Okay, next slide, please. And if you can just show everything on the screen. Thank you. Okay, so this is just showing us what actually would have been missed in this one review if these 2 studies hadn't been included. So again, this was a review on interventions to promote engagement in a school environment. So the first study that was missed both at the 80% and above threshold was a study by Whitten et al. It was only one of 3 individual studies that were ultimately included in the review that looked at inclusivity-based interventions. It was a moderate quality study and had positive findings. But you can see here that based on the 3 single studies, our grade certainty of evidence was generally on the low side. So removing that study possibly could have reduced our certainty to very low. So some impact, but not a massive impact on our findings. And this study was generally in line with the other 2 single studies that were found. The second study that was incorrectly excluded by AI was a study by Van Risen et al. It was one of 6 studies that was ultimately included in the review that looked at involving students in leadership roles and within restorative justice programs in school settings. Um, so sorry, that should say one of 9 single studies. So it was 9 single studies and 1 synthesis. This was a high quality study that had positive findings, very much in line with the other studies that were included. So if we had missed this study, it likely wouldn't have changed our overall findings much. We had 1 review and 8 single studies instead of 1 review and 9 single studies, all with very consistent findings. So this may have had sort of less of an impact overall. Next slide, please. And this is just another example and graph showing sort of that time spent screening, again, in that sort of trade-off of the cost and benefits. So this is an example of the time saved in one project in terms of the amount of screening that was left. So you can see at the 60% threshold, AI was able to remove quite a bit of the references. And then as we get higher and higher, and you do more manual screening to get to that threshold, the time saved decreases a bit consistently as you go up, which makes sense. Okay, next slide, please. So just that time saved really is, again, going back to this image that we saw earlier, there's a difference in the time saved in the screening the remaining studies after the AI threshold has been, or the AI screening has been integrated, and the number of references that you need to screen to get to that point. So while when we get to the 90 and 95%, AI is removing the vast majority, if not all, of the remaining studies, it takes you a lot more screening to get to those thresholds. So again, it seems like 85% is kind of that spot where we really on average had to only screen about half the references overall in that review, and we were fairly confident in those findings. Only in one study we missed one article, which didn't appear to have a huge impact on our overall findings. Okay, next slide, please. So key takeaways, and we'll have, I see there's some questions coming into the Q&A already, so we should have lots of time for discussion. So based on the findings from our study, AI really can be used to exclude a substantial proportion of studies at the title and abstract level. And again, we think that 85% may be kind of that the 85% threshold may be that sweet spot where we are reducing kind of the largest number of a good deal of the studies that need to be screened, but we're not missing out on a lot. In 6 out of 7 of our analyzed projects, AI didn't miss any of our included studies, which is great news for us, because that's something that we're really concerned about as we move towards using AI, is making sure that we aren't going to be biasing our results because of that. And by using AI, we can save up to about 50% of our screening time at the title and abstract level, which has huge implications for how quickly we can get through the review process. It frees up more of our staff time to work on the later stages of the review process, which I think are more important, to use that human brain. So looking at the full text for those more nuanced inclusion and exclusion criteria, being able to extract data accurately, being able to synthesize that data together, which takes a lot of time and effort to do well. So when we're on really tight timelines in conducting a rapid review, we want to make sure that we're maximizing our time on those more complex steps like synthesis, like grading the evidence, and not utilizing the time that we have to complete the review on a task that's more straightforward and tedious, like title and abstract screening, although still very important. Okay, next slide, please. So some challenges and certainly some limitations to this study. As we look at as we collected our data using the AI at different thresholds, we often saw what we called sort of a jump in the re-rank, which made it difficult to capture at those exact likelihood thresholds. So as we screened, we periodically checked that re-rank to see what percentage we were at. Sometimes just based on the nature of how the AI was learning, based on the number of studies, we may have been at 55% waiting for that 60% threshold, and then it may have quickly jumped to 70%. So we weren't able to capture that 60%. So there is a little, it's not an exact science in terms of those percentage of thresholds that we were getting. There is a little bit of variation, and it was difficult to capture each threshold in all of the projects that we looked at. There's also a little bit of a black box in terms of the AI features that Distiller uses. As I mentioned, this is not an AI feature that we created on our team. These are the AI features that are already built into Distiller as a software and as a project. And so we have no ability to sort of tweak that model in any way, or to even really understand kind of what's going on sort of under the hood. So there's a little bit, there, if we were to have that and have that knowledge, we could probably tweak some of this a little bit more. In terms of the timing estimates, Distiller does automatically capture some of the time, or the time that an individual is spent in the software screening, but there are some limitations to that. For example, if someone opens up a reference and then goes to the washroom or goes to grab a coffee, it still tracks that time sometimes, but not all of the time. So we did sort of review the time estimates, and when we saw that there were really sort of unrealistic time estimates, so 10 minutes spent screening one reference at the title and abstract level seemed very unrealistic. We removed that. But I would say these are timing estimates on time spent screening. I wouldn't take these as absolute values, but I think still gives us a rough guess on our time that's saved, also knowing that every individual screens at different rates. So we have a good estimate, but I wouldn't take these time numbers as absolute values. In terms of next steps, we are going to go through that check screening errors function. We did look through that at a preliminary level, and then we'll be calculating the specificity, sensitivity, and accuracy. But as I mentioned, we're really more concerned about those false false excludes, false negatives. So sometimes the sensitivity specificity numbers are not as meaningful to us, where our main purpose is making sure that we don't artificially exclude things, but are still saving some time in the process. Next slide, please. So in conclusion, AI really may be a promising support tool for improving screening efficiency. I think we definitely see it as a tool to assist our manual screeners, not something that would be replacing our human screeners. I think there's still lots more that we can learn here about how AI can be most appropriately integrated into rapid reviews, not just at the screening level, but beyond. I think we also, are limited in, we had the time period of our study funding, and we utilized this protocol in all of the reviews that we conducted over that time period. But it's really difficult to determine what an appropriate sample size would be for something like this, unlike other studies where we can, determine the power that we need. So I think the more data, the better here, and certainly would be interested in just chatting with anyone else who uses Distiller for rapid reviews to see if there's ways that we could expand our sample size and then become more confident in our results. Next slide. And that is it for me. So I think we have lots of time for Q&A, which is great. Maybe Elena, I'll turn it back over to you.
Awesome. Thank you, Sarah, for sharing the results of your study within a review project. Obviously, AI is very timely, and I think everyone here is interested in seeing how AI can be used for rapid reviews. I have lots of questions coming into the Q&A, which is great. I did forget to mention earlier that you can also upvote questions in the Q&A. So if somebody has already asked something that you are interested in hearing a response to, you can like it with the thumbs up icon, and we will be sure to prioritize those questions. But we can get started, and please continue to add your questions to the Q&A. We do have lots of time for this discussion. So I'm just going to go in kind of chronological order as the questions came in, I think. Or let me Actually, I can sort by most upvotes. So the first question I have for you, Sarah, is from Cecile. She's just asking for clarification on whether the more you screen manually, the better the AI performs.
Yes, I would say um, yes, the more you screen manually, the better AI performs. Um, and then it gets to a certain, it's if we go back to the slide with the graph with the yellow line and the maroon line, there does come a point where, so we see at those, oops, yeah, yeah, this one's fine. So at sort of that 90 and 95% threshold, so when you've screened up to what Distiller predicts, Distiller predicts you've found about 90 or 95% of the eligible studies, the AI is screening out almost all of the studies that remain. But you do have to screen more to get to that point. So it seems like 85% might be that sort of optimal point where or the point where you actually have to screen the least number of studies. So you don't have to screen as much to get there, and AI still screens out most of the remaining. When you get to 90, 95%, it's getting rid of almost all of the studies, but you have had to manually screen more to get to that point. So it seems like 85% is sort of that point where it actually it reduces the greatest absolute number of studies that you need to screen. Does that answer your question?
Okay, we have another question here from Sarah from Public Health Ontario, wondering how do you think the AI's performance screening and identifying relevant studies might be affected by the heterogeneity of the studies included in a review? I can see it performing better for a very specific research question where the titles or abstracts of all the included studies contain the same words, but many public health research questions are broad or multidisciplinary. For example, a review on the food environment may include studies on many different types of interventions implemented in different settings.
Yeah, and Sarah, I have the same concerns. Absolutely. I would say, I mean, anecdotally, it does, when we look at those kind of thresholds, getting to those thresholds, um, when we have like a more heterogeneous or complicated question or less clear cut question, it takes more manual screening to get to that 60% or that 70%. So the graph that we have on the screen right now is an average across the 7 projects, but I would say there's huge variability in terms of the number of references you need to get to that initial 60 or 70%. I will say that with all of the reviews that we did, with all 7 of the reviews are more, I would say, very representative of public health related questions in terms of that kind of messiness. Um, the wildfires, air filtration and masking ones are maybe the 2 more clear cut, more straightforward ones. And I would say those ones we probably got there faster compared to the others. But all of the questions that we get are very, very public health focused, very, lots of different terms used and lots of messiness to get there. So I would say that this definitely applies to the kinds of questions that you would be getting at PHO as well. I think we probably work with a lot of the same challenges in terms of the types of evidence. So I would say yes, it does take more to get there for the more complicated questions, but I think we can still get there and use AI to help us.
Okay, another question from Dave wondering why is it that the total studies identified, so the maroon line in the graph, drop after 85%?
So I think that's where, because to get to 9, this is the total number of studies that AI can screen for you to get to 90 or 95%. There's more manual screening that happens. So you might screen, and this is just off the top of my head, and it's highly variable among studies. You might have to screen 500 studies to get to the 60% threshold, and then 700 to get to 70%, and then maybe 1,000 to get to 80, and it might be 2,000 to get to 90%. So even though you've screened out most of the rest of the studies at 90 or 95%, you had to screen a lot more to get to that threshold. So 85% seems, it's kind of the law of diminishing returns. The more you screen, the less it can screen out for you, if that helps to clarify that. So the yellow line on the top is the number of remaining studies after the manual screening is done. So you can see at 90 and 95%, it screened out almost all of those that were left over. And then the maroon line is the total number of studies that AI screened. So removing the ones that you had to manually screen to get there and manually screen after AI has screened.
Thanks, Sarah. I have a question from Lauren. How were the percent thresholds established? What was the 100% references to determine those thresholds?
Yes, so the threshold is a prediction from AI. So AI is predicting as you're screening that you've found 60% of what is there to find. So as you're screening, it assigns these prediction scores to all of the remaining references from based on machine learning. So you can at any point take a look and say, of all of my, let's say 2,000 studies that are left here, it has continues to reassign and reassign a prediction score that tells you how likely it thinks that study is to be included in your review. So those thresholds are all AI kind of developed. What we compared to in terms of the true was we had done the review within all manual screening. So when we compared sort of the accuracy, it was all compared to manual screening. So some only humans working across that whole project, but those percent thresholds are all what AI predicts. And so they weren't all, I wouldn't say they were all accurate. So if we were to say, look at 85% and AI predicts that 85% of the studies were found, sometimes all of the studies had been found at that point. Sometimes 70% of the studies had been found. So there is some variability, but we just use those because when you're working in it in real time, those are the numbers that you have to work with.
Okay, I have a couple questions just regarding Distiller. So one on whether Distiller is a free tool or not, and what was the reason for choosing Distiller over Covidence because it
Yes.
uses AI as well.
Yes, so I will say, so Distiller is not a free tool. You do have to purchase a license. I'm not sure the cost exactly. It depends on whether you're in an academic institution or a nonprofit or a private sector. So there's a number and the number of accounts you have and review projects, etc. So I can't speak to the price exactly, but it is not a free software. So we have used Distiller for quite some time. We use it as well. One of the products that we have as part of the NCCMT is health evidence. We've used Distiller for a number of years to help screen for studies that are included in our health evidence database. So we have used Distiller for a long time. We find it very user friendly. And so it's just part of what we've done for quite some time. Covidence does have AI features within it as well. I and it may have changed more recently. I haven't used it in the last couple of months, but it does have that re-rank function where it brings the more eligible studies to the top of the list. In sort of anecdotally in using it, it doesn't seem quite as useful as the re-rank in Distiller. And it also doesn't have AI screening to my knowledge at the time. Definitely at the time we were starting this project, it did not have the ability for AI to screen out studies, only to bring the more likely studies to the top of the list. So that's why we used Distiller for this, because it actually had the ability to screen out studies so that a human would not have to do that piece. And these things I would say, caveat is that these are changing all the time. So it's like it's entirely possible that Covidence has new features. All of these are constantly changing and quicker than we can all keep up with. So
Okay, a question from Aaron wondering about whether the time for manual review was that for one reviewer using the Daisy feature?
So, yes, great question. Typically, what we do within our reviews, because these are rapid reviews and we have to sort of accelerate the timeline from our traditional systematic review processes, is that we have two reviewers screen roughly the first 10 to 20% of our eligible studies. Um, so once we seem to have like got good agreement on those, we feel confident. Then we switch to single screener. So that includes the time spent screening by both screeners in that initial phase and then moving into single screener later on.
Hey, and another question regarding screening from Frederick. Is the AI's accuracy dependent on the input from the screener? How much training is required to learn how to properly screen for AI rapid reviews?
So yes, I would say certain definitely. The you can the we definitely see when because in that those early phases where we're using two screeners, and those are also the time that the Daisy function is learning and starting to kick in. The better and faster we can get those two screeners kind of calibrated, and we feel better about we more confident in those and less conflicts. The faster the Daisy seems to kick in and do a better job of bringing the really eligible studies up to the top first. So we do have in some questions that we receive, it's very easy to determine at the title and abstract level whether something is in or out. In others, we end up having to be really overly inclusive at that title and abstract level because we can't really dig into we can't really determine eligibility until we dig into the full text. So I would say those ones where we're able to more easily screen at title and abstract level, the Daisy feature kicks in earlier and does a better job compared to those more messy questions. And so I think that's the result of two things in terms of screener quality. One is, are the screeners being really accurate? Do they understand the question? Are they being consistent in the way that they're determining include or exclude for those studies? And then two, also how clean cut is that question? Is it easy to make that discrimination at the title and abstract level? But yes, I think anecdotally, we've noticed when we have, if we bring a new screener on board and we're just training them on the process, and it always, takes people a bit of time to get up to speed or feel confident in those. If when we are training somebody new, it does seem to impact the AI a little bit as well.
Hey, we still have lots of questions coming in, which is great. Um, are there any specific characteristics that could explain why there were AI screening errors on the school engagement project, but not the other six?
Yes, we've talked quite a bit about this on our team. I would say that review was one of the ones where the question and the eligibility criteria was a little bit more difficult to determine. So when we think about interventions that can enhance school engagement, that was called a whole host of different things. Um, and you could even see in those examples, it was interventions that were bringing students into leadership positions to enhance engagement in the school context. It was looking at interventions that promoted inclusivity for LGBTQ plus students. So there were a whole host of different types of interventions. We weren't looking at a specific intervention, more of a category of interventions that were aiming to promote a specific outcome. So that could be it. Although I would say that our public health messaging review also was very messy, although didn't have very many eligible studies. So that might have been why nothing was really missed because there wasn't a whole lot there. So I think, loosely hypothesized that this might have been because it was a more difficult to sort of assess question. Although it's not to say that the others were all clean cuts. So that's what we think. But again, with only 7 reviews, it's really hard to draw those conclusions. I'd love over time to have a larger data set so we could be a little bit more confident in that.
Another question here from Cecile asking, would you consider this approach in a non-rapid review environment, such as a systematic review, a scoping review, or meta-analysis? Or do you feel it's most appropriate to the need for speed of a rapid review?
Yeah, it's an I think it's maybe a more like review philosophical question. I think at this point, we're still very much in the data gathering kind of stage of determining how accurate we feel AI is. So if you were conducting a full systematic review, I think there would be many folks who would say, no, if you're doing a full systematic review, your goal is to get all you want to be most comprehensive, get all studies that have addressed this question. Being the most rigorous and comprehensive should be manual screening. I think that that's probably something in the future. I think there's lots of conversations happening in groups like Cochrane and other systematic review groups that there could come a time where certain AI features have been developed and tested sufficiently that they could be included maybe as a second of two screeners in a systematic review. But I'm not sure that we're there yet.
Brian from Peel Public Health has a question. Can you speak to the potential role of AI to eliminate duplicate records or
Mhm.
deduping references?
Yes, thanks, Brian. So i- both Distiller does have a feature that that identifies duplicates when you import, just like Covens and even EndNote have dedupe features. I'm not sure off the top of my head whether that uses AI or whether how they go about that. I mean, I know it's been a feature that's been in there for a long time, and note all of them have had dedupe. And I don't know if they use AI or what methods they use. Alana, do you know? Because you.
Yes. So I know for sure for Distiller that their dedupe does use AI, basically looking at like the title and abstract to see how many words match
Mhm.
between the two. I can't really speak to how accurate it is, off the top of my head, but it does exist.
Thank you. Yeah, and I would say we haven't really tested that. We've just sort of taken that um, as it works in terms of deduplication. Um, of those within our reviews, but we use a more conservative. There's different approaches that you can use to reduce duplicates. I think we use a more conservative approach, and you can review them. So there likely is a role there. I think it's probably already being used, but we haven't really tested or looked at that comprehensively.
A question from Lisa wondering about the first stages of defining the research question, inclusion, exclusion criteria, and identification of sources. Do these steps remain manual and dependent on librarian support, or is this part of AI as well?
So we have not. Well, I would say officially, we have not these still remain very manual steps from our on our end. Certainly the development of the research question and eligibility criteria, I think, will always remain so. We need to understand the question and the needs of the decision maker. So oftentimes, when we receive a question from an organization, it might be a really broad question. We'd really like to know. Let's just use the school engagement as an example. We'd like to know what interventions should be put into place in schools to increase engagement. So that's a really broad question, and it often takes some work with our team and the person requesting the review to really understand what their needs are, what types of information they want to get out of it, what is this going to be used for, and that helps us determine what we should set our eligibility criteria for. Given that these are rapid reviews and we can't look at everything in a short time period, we have to make those decisions, and that's based on the priorities of the person who's asking for the review, because we aren't conducting these reviews just for the sake of doing a review. We're doing them to inform a specific decision. So that really has to be based on the needs of that organization or that decision maker. So that still remains, and I think will always remain very manual or human focused. Where we have dabbled a little bit is in developing the search strategy. We are fortunate at McMaster to have relationships with librarians, but we don't have a librarian on our team. So our access to a librarian might not be, sometimes there's a little bit of a lag between when we get a question in, when we can meet with them. So certainly we still do collaborate a lot with those librarians, but it's often us developing that initial search strategy, working with them to make sure there's not any holes. So we have dabbled a little bit with AI in helping us to draft up that search strategy. But very much in a brainstorming way, and it's still very much working with a librarian to finalize and do that. I was recently back in June. I was at the Canadian Health Librarians Association conference, and there was quite a few presentations there on using AI to develop search strategies with some sort of mixed results. So I think that there's definitely an opportunity for AI to help with some of that, but I think again, using it as a tool to assist versus replacing that librarian support.
A couple more questions just regarding Distiller itself. Sarah, do you know the source that Distiller AI works on? Does it work on top of known sources like PubMed, Medline, or other databases?
That I don't know. In terms of how we are using it here with screening, it's really learning based on our screening patterns. So the titles and the abstracts of the studies are imported when you have your EndNote file or your database file and you import it into Distiller, and it's learning based on what we have done. Elena, I don't know if you might have more knowledge of.
I don't, unfortunately. We also, for health evidence, use it in a very unique way, which I don't think many others do. And that took years of training to get to that level.
Right. Yeah, sorry, I can't answer that question very well.
Sarah, do you have any other experience setting up AI-assisted rapid reviews outside of Distiller using maybe any other programs or softwares?
I do not. I know there are lots of other review groups who are working on this. Happy to connect after offline if you'd like to send me an email, and I can connect you to a few other people I know who have been doing a little bit of this. But we have been exclusively using Distiller, and one of the big reasons is that we are not computer scientists and do not have computer scientists on our team. So that whole development piece is definitely outside of our area of expertise. What we know really well is reviews and review methods. And so using these features that are already available and testing them to see if they really fit our needs. But that piece is definitely outside of our scope, but I do know of a few other folks. So I'm happy to make those connections.
Okay, questions are starting to dwindle, but there's still a few. Sarah, were you able to use AI for gray literature reviews, or maybe I guess did you include gray lit in the rapid reviews?
Yes, so some of them did include gray lit in the rapid reviews. It's we still did that process of, if we were looking at a website, for example, like screening that website and then those results being imported into Distiller and then screened the same way within Distiller as other academic sources were. So there definitely were some gray literature sources in there, and they underwent the same kind of screening process. Nothing separate happened, and we haven't used Distiller to, for example, if there was a database or a website that we were screening from a gray lit perspective, we haven't used AI to sort of do that on those platforms. Just anything that have been able to import into Distiller.
Given that AI methods are kind of a black box, do you have an approach that could help identify differences in AI performance after it has been updated? For example, changes in the distiller algorithm or program.
Yeah, this is something, I mean, so I guess two answers to this. In terms of our rapid review screening, because the because the algorithm or AI learns with each individual review, um, we anticipate that to, I guess, become more effective, but the same process is in place. It's learning freshly from every review that we have because we have a new question, new eligibility criteria. So as we screen, so we would expect that, if there were updates to that algorithm, that the Daisy feature may kick in earlier or may, but we would still take that same approach. I guess if there were substantial changes, we may consider, I guess, replicating the study in the future to see if maybe we could use a lower threshold. But because it's learning based on each individual study, there isn't necessarily a need to retest, or because it's not using the same model every time. I mean, this is a little bit different to how Elena was describing how we use AI and Distiller for health evidence, where we have the same eligibility criteria for the database, that where we import and screen results with the same criteria every month on a monthly basis. And so we have developed our own uh, threshold or criteria just specific to health evidence, because that means is maintained over time. And we do quality assurance checks on a regular basis to make sure that that model continues to work well for us, that there's no changes both from the model perspective, and also any sort of AI drift in the effectiveness of that model. We know that new language and terminology is used. So we do ongoing quality assurance checks within health evidence. But that's a little bit of a different use case because it is essentially the same eligibility criteria that are being used on a monthly basis over time, versus when a rapid review, where every review you're starting is answering a new question, therefore has new eligibility criteria. And so the AI feature is learning fresh every time.
Okay, and just a couple more questions. One from Lauren, which she thinks you might have answered already, Sarah, but did you have to restart at zero to establish the thresholds for each of the 7 study reviews?
Yes, yes. So because they're each a different question, they're learning fresh each time as you start that manual screening process. Yeah.
Awesome. Question from Kathleen. Do we know if there is any hesitation or reluctance on the part of academic journals to publish rapid or other reviews that have used AI in their screening process?
hmm Um, I mean, I certainly can't speak to all. Um, we have published some of our work that has used AI in that process, and we've just been taken the approach of being very transparent about how it's been used, and that seems to have been okay. I think, again, kind of going back to that question, is it okay in a rapid review versus a systematic review? And I think it just being transparent and knowing the process. So I think in a rapid review, we know that there are shortcuts or streamlining of the traditional systematic review steps that are used in every rapid review to meet those timelines. So whether it's using single screening versus dual screening, it's limiting the number of databases that you search, those types of things. So just being upfront and transparent in, if you're publishing a rapid review, what are those streamlining steps that you've taken, and AI could be one of them. I think it might be different in a systematic review if you are trying to publish. I believe the last I checked, Cochrane was not allowing the use of AI in any of their reviews. So if in terms of screening, so if you were looking to do a Cochrane review, that would probably not be accepted. But again, it is changing quite rapidly, so it's not to say that in the future that might not be an acceptable step.
Okay, and then related question, do you expect to publish the results on this study?
Yes, we do. We are working on a manuscript right now, so we hope to submit that shortly, and then that will be available.
Okay, and then one just follow-up question I have added to the slide here for you, Elizabeth. Can you remind us what was the time saved by using AI at 85%? I have added it here on the slide too.
Yeah, and thanks. And I'll just say this is an example from one project. So if we actually go back to that line graph that had the yellow line and the maroon line. Yeah, this one. So 85% It was just on average across the 7 reviews, it was just over 50% of the total number of references. So again, we had a huge range from I think around 700 to almost 12,000, and it cut it in just over half.
Awesome. Thank you, Sarah. That was a lot of questions. Hopefully everyone got the answers that they were looking for. Um, I am going to continue on and do kind of a bit of our webinar wrap up with our last remaining time. If you do have questions, though, please feel free to contact us via email and we will make sure that we get back to you. And I'm sure Sarah is happy to chat more about this if people have more in detailed questions that they want to ask. But if you're interested in the webinar today and you were interested in learning more about the NCCMT or maybe trying out or attending any of our other upcoming events, we do encourage you to visit our website. You can create a free account, which will allow you to sign up for events. You can try any of our resources, such as our learning needs assessment or our free online learning modules. We encourage you to subscribe to our newsletter as well. This is probably the best way to keep up to date with different workshops and webinars that we are hosting. There's usually something on the calendar, so it is a great way to keep up to date with what's going on at NCCMT. You can follow us on LinkedIn and YouTube. As I mentioned before, the session has been recorded and we will make the recording and the slides available to you. Typically, about a week or so after the session, we will post on LinkedIn just to alert everyone that the recording and slides are available. And you can access those through your dashboard or you can email us to get a copy. I also just want to bring to everyone's attention, we have opened applications for our NCCPH Knowledge Translation Graduate Student Awards. So if you are a student or if you know of a student who is doing knowledge translation work in public health, we do encourage them to apply for this award. This is one of our collective NCC for Public Health initiatives that is used to support and recognizes the efforts of Canadian public health scholars. And we run this award every year. There are 3 prizes of $1,500 that will be awarded during the Canadian Public Health Association's annual conference, which will be held in Montreal in March 2026. The award winners will present their KT research projects at the conference and will have the ability to network with other public health professionals in Montreal for the conference. And application deadline is December 1st, so there is still a little bit of time to get those applications in. At this time, I'm also going to ask Krishan to open our last polling questions for the session. This just gives us a sense of how you liked the webinar, and we can use this feedback to improve upon sessions in the future. So please, if you have the time, it would be super helpful for us if you could complete the post-webinar evaluation question. And I will also leave it on this slide. Here is our contact information. So I really do encourage you, if you have more questions about using AI and rapid reviews, or questions in general about the NCCMT or evidence-informed decision-making, please reach out to us. We are happy to connect, and someone will respond to your email within about a business day or so. So thank you everyone for attending. Thank you so much for all the amazing questions. Thank you, Sarah, for sharing all of your work on this project and all of the findings. Okay, thank you everyone for joining today's webinar.
Thanks, everyone.